Sir, we are live now on Facebook as well, sir.
Okay, thank you. Well, dear colleagues, welcome back on Sunday evening EUS ERCP workshop. And this time we have Professor Ken Cheng. Dr. Mustafa Rai is going to introduce him to him. Dr. Mustafa, all yours, please.
Thank you. Thank you, Dr. Vyas and Dr. Saad, once again for having me, as well as thank you, Dr. Professor Chang, for joining us. For anybody who's in the field of EUS, especially, Dr. Chang is a very familiar name. He's a very recognized and established name in the field who is a professor of gastroenterology as well as the department chair for gastroenterology and the head of the Institute of Gastroenterology at the University of California, Irvine. He is a pioneer in the field of endoscopic ultrasound, especially, and has been one of the early sort of adopters and describers of various techniques of endoscopic ultrasound, including endoscopic ultrasound sampling, injection, as well as therapeutics, including ways of treating cancers, not just using EUS, but non-EUS endoscopic modalities. Um, when I first started doing this about 10, 11 years ago, I actually had the privilege and pleasure of visiting Dr. Chang at UC Irvine, and subsequently have made several trips down to his center. And every time it's just been a pleasure, not just to sort of visit his center, but to spend time with him and learn his very, very meticulous and detail-oriented sort of approach towards endoscopy as a whole and EUS especially. Beyond that, he's an expert overall in multiple other techniques, including anti-reflux procedures, ESD, POEM procedures. So you're just going to see one angle and one aspect of his expertise, but we're very, very fortunate to have Dr. Chang join us at 5 a.m. here in California. So thank you, Ken, for joining us and for sparing the time for this very valuable lesson in the field of endohepatology.
Thank you so much, Dr. Rain. Thank you, Dr. Tayeb, for this kind invitation. I spoke at the Liver Society meeting a few months ago, and I'm glad to be back to be able to spend more time with my Pakistani colleagues. So I will share screen. I think it's already shared. Okay. All right, so today I'll talk to you about EUS and a rather new field, which I call endohepatology, where scope meets liver. These are my disclosures. And this is something I thought about and wrote about back in 2012, the idea that as endoscopists, as endosonographers, we own and command the pancreas, right? We biopsy, we image, we drain, we put stents, we take care of the necrotic debris and walled off necrosis. And so we own the pancreas. But if you think about the scope and the liver, we really don't. We tend to outsource imaging, CT and MRI, biopsy by interventional radiology, the TIPS procedure. So we have not done justice to our liver as we have to the pancreas. And so the idea of endohepatology is to think about that possibility that we can actually do much more by way of endoscopic diagnosis and intervention in the liver itself. So as Mustafa mentioned, I've been doing EUS for a long time, 32 years now. And so one of the things I love to do is, and by the way, the liver is one of my favorite organs. I love hepatology. So every time I go by the liver, I like to do a poor man's liver biopsy by doing a palpation. So this is the beginning of endohepatology is EUS guided palpation. So you can see just by indenting on the liver with a radioscope, and you can do this with a linear scope, you can assess how soft or firm the liver is. And this costs nothing and takes a few seconds. So we can learn a lot just by palpating the liver. And as the concept of endohepatology emerged, who would have known that at the same time there would be a worldwide epidemic in obesity and fatty liver? And this is true in the United States as well as it is in Pakistan, that it's a growing number of adults as well as young adults are being diagnosed with NAFLD and NASH. So in the US, nearly 1/3 of every adult will have NAFLD, and 5 to 10% of our adult population will have NASH. And then 1 to 2% of our population will have fatty liver related cirrhosis. And from there, half will die or need a liver transplant, and 7% will go on to get liver cancer. So NASH is projected to overtake Hep C as the leading cause of liver transplants in the United States, and I'm sure in many other countries. And as we look at this very scary spectrum of disease, we notice that there are maybe two areas where there's an unmet need, where as endohepatologists, we may have a role. One unmet need is, despite all the wonderful non-invasive tests that we have, I would say that you cannot make a diagnosis of NASH firmly without a liver biopsy. So one area of need is here, being able to sort out which patients have NAFLD and which patients have NASH. And EUS guided liver biopsy, I believe, will become more and more important in this space. The other unmet need would be in patients with NAF or NASH, with NASH or any other liver disease, Hep B, Hep C, and autoimmune hepatitis. We don't always know where they are in their progression towards cirrhosis. So NASH obviously leads to cirrhosis, and if you're going to intervene, you want to intervene before the cirrhosis is irreversible. And so there's another area of unmet need here, and I believe that's where EUS guided portal pressure gradient can really help determining where the patient is in that progression towards irreversible cirrhosis. So two areas of unmet need that I'll circle back to as we continue in this journey. So the first real entry point for endohepatology has been our ability to do liver biopsy well and do it safely. And so this video demonstrates the technique of EUS liver biopsy. So here we're looking at the left lobe of the liver. This is a 19 gauge standard needle. The needle is advanced into the liver parenchyma, and the needle is primed with heparinized saline, and there's a large syringe applying negative pressure. So the first part of the procedure is just to put the needle in its starting position within the liver parenchyma, and I'm going to do an actuation. The actuation is turning on the suction and then advancing the needle very quickly into the liver parenchyma. Here, look at my trajectory. We want to find a safe pathway for the liver. I'm going to apply suction. Turn the suction on. And go. And a very, very fast forward motion. So this is called single pass, single actuation, where I do the actuation just once. But I find that with these standard needles, typically I'll do 3 to 5 actuations in each of the right and left lobe. I'll keep the suction on. So here we can start pulling the needle back, and we turn on the E-flow just to see if there's any flow in the needle track. And there are different things we can do if the flow remains. There are different things we can do to stop it from bleeding, and we'll go over that in a little while. But after we confirm that there's no flow in the needle track, we can remove the needle, and then as we process the specimen, you can see a very nice long piece of liver with a single pass, single actuation. Now, if we simply do a few more actuations, this is a demonstration of 3 actuations, and you can see we've got about 12 centimeters of liver tissue here. So you can get more and more liver by doing more actuations, and since it's only a single pass, you're actually violating the liver capsule once. So it's a very efficient, very safe procedure. And there have been a number of studies looking at the outcomes. This was done by the group David Deal, and he looked at 110 EUS liver biopsies compared to 27 percutaneous and 38 transjugular. And he showed that essentially the EUS gave the superior yield, especially when EUS can sample both right and left lobe. As you know, percutaneously, it's always the right lobe that's sampled. The left lobe is difficult to sample percutaneously, whereas with EUS, we can sample both lobe, and sometimes there could be lobular variability. So both lobe gives us higher number of complete portal tracts as well as the sampling error decreasing. So many abstracts and papers looking at the effectiveness, and the suggestion is EUS liver biopsy may be more cost effective than percutaneous liver biopsy in patients with NAFLD. This has to do with the cost of recovery. Patients have to recover for 4 to 6 hours in our institution if you do a percutaneous, and that's a lot of resource. And if they bleed or have pain, that requires an ultrasound, a hospital admission, overnight stay, and so on. So the cost of a subcapsular hematoma can actually be quite expensive. So when you roll all that up, EUS guided liver biopsy may be more cost effective. Then we enter into the era of the specialized tip core needles, which are very sharp. This is the fork tip. This is the Francine tip. And then we have the Mangini tip. So the tips are modified and they're very sharp. And this has resulted in even better yield on liver biopsy. So this is using the Francine tip, which has 3 sharp tips. And this is a single pass, single actuation. And you can see here 8 centimeters of continuous liver tissue in just one pass, one actuation. So we're getting very, very good at getting very nice liver tissue parenchyma. So very long cores, and when the cores come out, you can play around with it. And these are my initials after 2 passes, one in the right lobe and one in the left lobe. But if you look at the pass on low power, you can see it's completely intact. And then if you look at high power, just look at the edges of the specimen. The cut is very, very pristine, very clean, very sharp. And so you have less fragmentation, and you can see the quality of the specimen is superb. And this is using the trichrome stain. Here's a nodule about to form. Here's a infiltrated portal tract. Even dense fibrosis can be seen with a very sharp needle. So there have been a number of studies comparing now needles, and this compares the Francine tip to the standard needle. And the Francine tip portal tracts, the mean was 18 using a standard needle, and using the Francine tip, with the same technique, the number of portal tracts more than doubled at 42 complete portal tracts. This is a study comparing the Francine needle with the fork tip needle. This was in an abstract, 336 consecutive patients, and they showed that the two needles were similar, 22 complete portal tracts with the Francine, 19 complete portal tracts with the fork tip. Well, we recently published our own study looking at Francine tip versus fork tip, and this was just single pass, single actuation. And we found that the Francine tip, once again, was superior with the 14 complete portal tracts versus 9 with the fork tip. Now, both are quite adequate for clinical use and gives a diagnostic yield, but the Francine tip seems to be the sharpest and gives the most pristine liver biopsy. So this is the low power showing and the gross specimen in the same patient, same lobe, a randomized sequence showing the a very nice specimen obtained. So I think EUS guided liver biopsy will become more and more important in distinguishing NAFLD from NASH and the other diseases. For example, autoimmune hepatitis almost always will eventually require a liver biopsy before starting treatment, and other liver diseases. So I think this is something that the hepatologists obviously command in terms of the indications, but we give our hepatologists a very comfortable way of doing liver biopsy, especially when we can give the patient multiple information at the same time. We can give them a liver biopsy, we can assess for varices, we can do shear wave elastography, and we can measure the portal pressures all in one session. So with the portal pressure measurement, I think that's where this unmet need is addressed, because we can now diagnose patients even pre-cirrhotic. Patients can have mildly elevated portal pressure down in the 6 to 10 range. And at that time, the patient, the platelet count is normal, the INR is normal, the bilirubin is normal, imaging is normal, but the patient is already progressing towards METAVIR stage 3 and 4 without clinical understanding of that. So portal pressures can be very helpful. So we began looking at EUS guided portal pressure gradient measurement back in 2012. We know that portal hypertension is a serious complication of liver cirrhosis, and the gold standard has been the interventional radiology procedure called the hepatic venous pressure gradient, or HVPG. And the HVPG accurately reflects the degree of portal hypertension and is arguably the single best prognostic factor in liver disease, as it guides medical therapy and it predicts liver decompensation as well as predicting the risk for cancer of the liver. So just by the way of review, the portal pressure gradient is merely the difference between the pressure in the hepatic veins and the pressure in the portal vein. And normal is anywhere equal to or less than 5 millimeters of mercury gradient. Anything greater than 5 millimeters of mercury defines portal hypertension. Anything greater or equal to 10 millimeters of mercury defines clinically significant portal hypertension, and anything greater than 12 represents a high risk for bleeding from esophageal or gastric varices. This is the traditional transjugular approach, where a catheter is placed into the internal jugular vein, advanced into the superior vena cava, and down into the inferior vena cava, and then advanced into one of the 3 branches of the hepatic vein. And typically, the catheter will fall into the right hepatic vein. Once the catheter is in the right hepatic vein, then the interventional radiologist will assess and record the intravascular pressure. We call that the free hepatic vein pressure. And then the catheter balloon is inflated, and the catheter is now wedged in the vessel. And wedging it wedging the balloon will allow the transducer to record the pressure that's inside the hepatic sinusoids. The hepatic sinusoids, if they're stiff, indirectly reflects the pressure on the portal vein side. So this is not a direct portal vein measurement. It's an indirect measurement by way of the wedge hepatic vein pressure. And it is not always accurate in that there are instances where it does not accurately reflect the pressure on the portal vein side. And one of those instances is in the prehepatic, idiopathic, non-cirrhotic portal hypertension patients. But so that's the wedge hepatic vein pressure. So given this background back in 2012, I began thinking and working on the possibility that we as endosonographers could measure the pressure in the portal vein directly, as opposed to relying on an indirect measurement, and also avoiding all of the complications and risk of a transjugular approach. So working together with Cook Medical, we came up with a very simple device. It's a handheld, disposable pressure gauge. It's a manometer, essentially, and it gives a visual display of the pressure. And that's connected to non-compressible tubing. The tubing is lure locked to the handle of a FNA needle, and then it is primed with heparinized saline or saline alone, creating a closed system. Once the needle is in the vessel, the manometer and the vessel are in one contiguous closed system. So we did a number of animal studies culminating in this publication in GIE in 2016, where we simultaneously placed a transjugular catheter by interventional radiology into the right hepatic vein and measured the free hepatic vein pressure. At the same time, you can see here on the x-ray, this is the EUS scope and the 25 gauge needle placed into the same vessel and measuring the pressure at the same time. And so we could get simultaneous free hepatic vein pressure. In panel B is the EUS image of the same scene in A and B. And in letter C, we see that we can place the 25 gauge needle directly into the portal vein, whereas by radiology, it's not possible, and they can do the wedge hepatic vein pressure. And we looked at the paired manometric data points, comparing the transjugular measurement and the EUS 25 gauge pressure measurement. And you can see that point for point, the correlation coefficient was 0.985, which was nearly perfect. Then we went on to perform the human pilot study. We published this in GIE in 2017, where we looked at the feasibility and safety of EUS PPG technique in humans. And we wanted to correlate the value of the PPG with the endoscopic and clinical evidence of portal hypertension in these patients with liver disease. So we did 28 patients enrolled, and we found that we were able to 100% of the time identify and access the targeted vessel and obtain meaningful manometric pressures. There were no complications in the pilot study, and I've done now close to 150 patients. There still remains no serious adverse events. The portal pressure gradient range was from very normal, 1.5, to quite high at 19. And this is our technique. First, I look at the 3 branches of the hepatic vein, and I'll target the easiest vessel, which tends to be this middle hepatic vein. Sometimes we'll go into the left hepatic vein, but rarely, if ever, into the right hepatic vein. And then we reposition the scope and we target the portal vein. And usually it's the left portal vein that we're able to target quite easily. So I'll show you a video of the anatomy. This is using a linear echo endoscope. We're in the stomach and we're imaging the left lobe of the liver. And this vessel here, this smiley face, is the left hepatic vein. This vessel, which is more of the elephant trunk, this is the head of the elephant, and this is the elephant trunk, is the middle hepatic vein. The middle hepatic vein, as we mentioned, is the one we target the most. This is the IVC, and then off of the IVC, you can see the right hepatic vein. So we can do pulse wave Doppler to get confirmation of the vessel. And this is the pulse wave. The pulse wave is very typical. It has 4 phases, A, S, V, and D. And that is clearly distinct from the portal vein, which is a venous hum. Here you can see the 25 gauge needle passing through some liver parenchyma. And that's a safety measure to always pass the needle through liver before entering into the vessel. And then once in the vessel, we just push a few drops of saline to clear the tip, and we measure the pressure here. The measure pressure is 13 millimeters of mercury, and we do 3 consecutive pressures. And here we see we're very precise, 13, 13, and 13. After measuring the pressure, we bring the needle back and stop. Before coming out, we stop to make sure there's no flow in the needle tract. This is the left portal vein, which is very well recognized by its pulse wave Doppler, its hyperechoic borders. And here the needle is entered right into the left portal vein. This is the umbilical portion of the left portal vein. And the pressure measurement is then obtained. Here we're getting 15, 14, and 14. So again, quite precise. The needle is brought back into the liver. We make sure there's no flow in the needle tract, and then we can safely remove the needle. So in this case, the pressure in the portal vein was 14.3, and the mean in the hepatic vein was 13. So the gradient is just the difference between the two, 1.3, which was normal. So the study conclusion showed that in this human pilot, the novel technique using a 25 gauge needle and a compact manometer was feasible and appeared safe, although you cannot overclaim safety with 28 patients. The values showed excellent correlation with clinical parameters of portal hypertension. And so since that time, this was a long time ago now, but as you know, it takes a long time for anything to clear FDA. FDA approved this just before COVID started in January of 2020, and then COVID hit us, and so we've really started launching this most recently, doing a lot of training. Dr. Arain is now well trained and performing this procedure as well. So we also looked at the feasibility of doing combination modalities in where patients would get simultaneous portal pressure measurement as well as EUS liver biopsy during the same session. And this is now our go-to combination. We do this on almost every patient now, and success is very high. And the nice thing is we can also correlate the liver biopsy and the portal pressure gradient measurement. And we found that the PPG was significantly higher in patients with a Medivir 3 and 4. As a matter of fact, we have a manuscript submitted to hepatology, and there was an oral presentation for AASLD on EUS PPG predicting Medivir 3-4 patients even before clinically appreciated. So what I'd like to do now in the last 10 minutes or so is to show you some videos of the procedure in the setting of clinical vignettes, so we can appreciate the utility of this in everyday life in patients with liver disease. So the first patient I'll present for you is a 74-year-old female, hyperlipidemia, hypertension, AFib, admitted 1 month prior with severe jaundice. Patient was confused. The bilirubin was 18. The patient had acute renal failure as well. The right upper quadrant ultrasound just showed some fatty liver. The common bile duct was dilated at 1.3 centimeters, and EUS was done. It showed some mild ascites, and it showed a tumor at the ampulla, which was biopsied and confirmed to be adenocarcinoma of the ampulla. During the time of the EUS, the shear wave was quite high, 28.9 kilopascals, And during the ERCP, a biliary stent was placed. So now, a month or so later, the patient is clinically much better. The jaundice has been relieved because of the stent. And the big question for this 74-year-old is she an operative candidate? Can she withstand a Whipple resection? Does she have significant liver disease? Does she have portal hypertension resulting in ascites, and which would make her a very high surgical risk? Or have things improved with the biliary stent placed? So her liver tests were downtrending. Bilirubin is 1.5. The platelet count is reasonable, 334. The INR is normal at 0.93. So the patient comes back for a completion of her endohepatology workup to assess her candidacy for a Whipple resection. So I will lower the volume of the in-room volume. So as you can see, just on the first few seconds, her liver looks quite normal. Echo texture-wise, the liver surface is nice and smooth. The liver edge is not blunted, and we do our palpation maneuver, and it's soft. So very interesting that it's not obvious that the patient has cirrhosis. Yeah, so the liver edge is nice and sharp now, and I'll just scroll through. This is called shear wave elastography. We can measure shear wave in the left and right lobe. And as you remember, the shear wave a month ago was 47. And so here we measure the shear wave in the left lobe, and we measure it 10 times. And now the E value is dropped way down to 12.4 from 47. So a dramatic decrease in the liver stiffness after the stent went in. Okay, so then we're also measuring the right lobe because we can measure both lobes, and it's 18.4, clearly better than a month ago. And now here we're going to do EUS guided portal pressure gradient measurement. Here we're locating the middle hepatic vein. We see the typical 4 phases of the pulse wave on EUS. Here the needle is in the middle hepatic vein, and I'll just zip through here. So the pressure was 10, 11, and 10. So that was the baseline pressure. The needle is now we're in the portal vein, the left portal vein. And we'll measure the pressure in the portal vein. It's 13, 15, 12, 12, 12. I did a few more just to be very precise. And so we get 12 as the portal pressure. So the gradient is only 1.66. It's normal. This patient does not have portal hypertension, and surgically is not a risk. So that's really useful information for our pancreas surgeon. And then on the same procedure, because we don't even know if the patient has any underlying liver disease. So on the same procedure, I'm going to do EUS guided liver biopsy to complete the endohepatology workup. And here we are, I'm using the Olympus 19 gauge Easy Shot 3. It's a Mangini sharp tip needle. And here I'm in the right lobe. And you can see in the right lobe, I've got a lot of distance of liver with no intervening vessels. So the right lobe is actually better than the left lobe for liver biopsy. So here's the needle entering into the liver parenchyma. Once I have my trajectory mapped out, a very fast jab. Here's the needle here. Now I'm going to bring the needle back. And then I will take a second actuation. So that's one actuation. I'll do a second actuation now. And the section on, and a fast jab. Let's set 2 actuations. I bring the needle back, and I'm going to do a third actuation. Okay, so that's 3 actuations. Let's see if I do any more. I think, yeah, that's it. I do 3 actuations. And you can see the needle track here. And initially there was some flow, but then with some time, it stopped flowing. And here I'm expressing all of that tissue out. And look at all that liver tissue that I got. Just a single pass, 3 actuations. That's an enormous amount of liver tissue. It would make any hepatologist very happy. And the liver biopsy just showed some mild hepatocanalicular cholestasis resulting from the ampullary tumor, some patchy, mild bile ductular proliferation, mild steatosis, and no fibrosis. So the patient was cleared for surgery and had her uneventful Whipple resection for her ampullary cancer. Okay, I'll do 1 or 2 more in a few minutes, so we have plenty of time for Q&A. This is another patient who is a 72-year-old male, hypertension, type 2 diabetes, hyperlipidemia, a BMI of 30, so meets obesity criteria, but has a pretty significant alcohol use history, quit recently, but has elevated liver tests. Bilirubin's 1.8, alkaline phosphatase 125, AST 66, ALT 34, platelet count slightly low at 140, the INR slightly up at 1.2. The MRI MRCP shows some hepatic fibrosis, maybe cirrhosis, some scan ascites, no fatty infiltrate in the liver, and a 1 centimeter incidental pancreatic body cyst. Rule out side branch IPMN. So the wife's main concern, which is always the important thing to listen to, the wife, is occasional confusion. So you wonder if the patient has started to have some encephalopathy. So we'll roll this video of the case. Okay. And so here in the first, let me lower the in-room volume. We're seeing trace amount of ascites. We're seeing now a non-smooth liver surface and a blunted liver edge. Here's the ascites, very scant amount. So already we're suspecting cirrhosis, right? Our palpation is very stiff. I tried to palpate and the liver moved away. And again, the liver surface is more nodular. So that was a quick endohepatology assessment. There's a regenerating nodule in the liver. And so then we go ahead and do shear wave. So shear wave is going to be high. And after 10 sampling, the shear wave E value is 43.8 kilopascals. And this is the left lobe, I believe. And then it's left lobe is 44.94. Right lobe is 33.5. So there's some variability between right and lobe, but clearly both lobes are quite abnormal. And then we go ahead and identify the middle hepatic vein, and we're going to do EUS PPG. And so I'll zip through that, and the pressures are 14, 13, 12 on the hepatic vein side. But more importantly, we want to know the gradient. So that's the portal vein. The needle's in the portal vein, and the portal vein pressures are 24, 25, and 25. So the gradient is 11.66, which is consistent with clinically significant portal hypertension. So then we go ahead and do a liver biopsy. Here we're doing 1 pass, 3 actuations. And here we go with pass 1. Actuation 1, actuation 2, actuation 3. We come out. And the liver specimen is a little bit more fragmented, but quite adequate. And what do we see? Advanced stage liver disease, no steatosis. And this represents a cryptogenic process, maybe burnt out steatohepatitis in combination with the history of alcoholic disease, but it's not reversible at this point. Having the patient stop drinking is not necessarily going to help him, and he's more or less on the way towards the liver transplantation. So that's another nice example of the role of endohepatology. And I'll finish with this last case. Yeah, this will be, I've got one more, but this will be the last one, so we have plenty of time. 55-year-old female with lupus and obesity, BMI of 33, chronically elevated liver tests. So this is our bread and butter NASH patient. ALT 97, AST 114, platelet count is downtrending, fatty liver, but could be autoimmune with ANA positivity of 1 to 160. But the FibroScan shows only F1, F2. So what we did, so here's the portal pressure measurement, and that's the needle in the middle hepatic vein. Pressure is 17. There's the needle in the portal vein, and the pressure is 23, 24. So the gradient is 6. This is very, very interesting, right? Because a portal pressure gradient of 6 is elevated. That's portal hypertension, but clinically, it's essentially subclinical, right? The platelet count was 198,000. The patient has no varices, no portal hypertensive gastropathy changes. You would not know that this patient is heading towards cirrhosis, but a portal pressure gradient of 6 in a NASH patient, now you really have to take it seriously. So because of the pressure gradient being high, and we confirmed the NASH diagnosis, the biopsy ruled out fatty liver. So I'll just speed. We did the liver biopsy. This is using the Francine tip needle. That's the 3-pronged sharp needle, and we got a great specimen. That's our specimen, and we were able to confirm this was NASH. This was advanced NASH with 3 out of 4 NASH score. And so there was absolutely no question that the patient has NASH and now has an elevated portal pressure. So the patient tried diet and exercise, which obviously doesn't work. And then this was in 2019. So I offered the patient an anti-obesity procedure, endobariatrics, endoscopic sleeve gastroplasty. So this is me doing the endoscopic sleeve gastroplasty. And the patient really responded well to the procedure, lost 60 pounds a year later. She's actually lost 100 pounds now, but at 1 year, she lost 60 pounds. And we repeated the liver biopsy, and the portal pressure gradient normalized. And let me show you the liver biopsy. This is the baseline liver biopsy. You can see a crazy amount of steatohepatitis, inflammation, steatosis. 1 year after the endoscopic sleeve gastroplasty, look at the liver specimen. There's like 0 fat now, no steatosis, minimal inflammatory reaction. What about the cirrhosis? This is the trichrome stain on the before, and this is after. Of course, it takes time for the fibrosis to resolve or reverse, but essentially all of the reversible components occurred within the 1 year and 60-pound weight loss. So this is where endohepatology meets endobariatrics. And I'll skip the last case. 64. And with this concept that now with endohepatology, we can deliver a one-stop shop endoscopic evaluation where we assess for portal hypertensive gastropathy, we assess for esophageal and gastric varices. On the same procedure, we can do EUS guided portal pressure gradient measurement. We can do liver biopsy as well as shear wave elastography in both right and left lobe. If you think about it, if we do this on these patients, the amount of information we can give back to our hepatology colleagues and impact the patient's natural history, and we can intervene much earlier. So with that, I'll leave 10 or 15 minutes for Q&A. Thank you very much.
Thank you, Ken. That was an excellent overview on the topic and some fascinating case examples, especially that last one is very, very sort of comprehensive and dramatic. So I will see if any of the other panelists, Dr. Saad or Dr. Vyas, have any questions to begin with.
Excellent talk, Dr. Professor Chang. That was
Saad.
really, really, really nice. And you made it appear very simple. Do, can you share the cost of this pressure assessing device that you've the Cook device? Number one. Number two.
Mhm.
Yeah, go ahead. I mean, I'll. The other thing was, now you've gone into the hepatic vein, you've got into the portal vein. I mean, you can see you've got excess. What about moving one step ahead with tips? Where is that something that you see as a possibility? Are you can you share any the progress that has been made or is being made on that?
Yeah. So the cost, I'm not exactly sure what the exact cost is. It's somewhere in the 12 to 1500 range as a kit. So the needle, the manometer, the tubing, everything is in a kit. So that's roughly the ballpark cost. But that's all, you know, and then Cook, you know, Cook is the sole manufacturer of the device right now. In terms of EUS guided tips, yeah, all of us have been fascinated with that possibility. You know, many of us have done animal labs where we've performed tips using expandable metal mesh stents, and we can connect the hepatic vein with the portal vein with this technique. The main issue with EUS guided tips is the possibility of introducing infection, which I think it'll be very hard for us to really remain sterile because we're going through the gut to do this. And so IR guided tips is very well done, very safe. So I don't really think that we're going to be an advantage. So I don't know if if EUS guided tips will become mainstream. But I think portal pressure gradient will change the terrain quite a bit because of ease of use and the fact that patients tolerate very well and we can get a direct portal vein measurement. I think we're going to find more and more use for this, you know, especially where liver disease is more prevalent. Um, you know, so I'm really pushing the company hard to offer this to Asia, where there's more liver disease than here in the West, even. So that's a work in progress.
Thank you very much.
Thanks, Dr. Saad.
Let's take
One of the
a question on liver biopsy. One of our colleagues wanted to know now what is the cost effectiveness. You, though in your talk you said that it's cost effective. It appears that it's more cost effective to do it US guided. But considering the expense of the US guided needle in Asian countries, especially in India and Pakistan, and the cost of Percutaneous biopsy needle, I think in our setup, we find it hugely different in terms of cost when we're doing a percutaneous biopsy as compared to the EOS guided biopsy. There's a huge degree of difference in the cost. And then there was another question on is any comparison doing EOS guided biopsy between non-cirrhotic and cirrhotic livers? Do you get the same kind of fragmentation as we do as we get when we are doing percutaneous biopsy?
Yeah, those are great questions. Yeah, so I think cost is probably individualized to countries and to hospitals. It's a little bit counterintuitive when these papers came out that it seemed more cost effective because, as you say, you're paying for the EUS and the sedation and all that. But I think where the economic balance is tipped is when the patient has a complication, is admitted. One hospital day here in the United States, the amount is exorbitant. So even one admission, even a 10% admission rate, which is roughly what our history has been for percutaneous liver biopsy. 1 out of 10 patients will have significant pain, and they'll get an ultrasound, and there's a hematoma, subcapsular hematoma. We admit the patient, and the cost will skyrocket in that cohort once you have that one patient get admitted. So I think that's where the cost argument may be. But again, in other countries where the cost of admission is not so high, and if percutaneous can be done easily and cheaply, and there's no significant cost to the prolonged recovery, then the balance may tip the other way. However, if you combine it with something that's already being done, so if the patient's already scheduled, say, for an endoscopy to look for varices and screen for varices, at that point, if you add the EUS, the incremental difference is not large, and now you're in there already, and then your liver biopsy will probably be less expensive than a separate percutaneous liver biopsy at that point. So, yeah. So I think if you consolidate things and you do things all together, it could be more cost impact, more economic.
Dr. Chang, you did with the help of the tip, the endoscope you used to look for the stiffness of the liver. It's all subjective. Any tips in that to the audience where they can do the same?
So the liver palpation.
Yeah,
Yeah.
liver palpation with the help of the tip, the endoscope.
Yeah, so it is very subjective, and I don't want to overstate or overclaim that maneuver. It's just just a poor man's look at how bad is the liver. But I do some quantification. So when I put the tip against the liver, I will measure the angle of the liver surface with the probe tip, and then when I indent, I can remeasure the angle, and the acute change of the angle gives me a sense of firmness. I've not calculated. I've got hundreds and hundreds of these for a fellow to work on, but so I think you can semi quantify it, but I'm actually quite satisfied with just the feeling and the visual and the tactile feel of rotating the knob against the liver. So it takes a few seconds and just gives you a sense. I mean, I think we can pull out normal, and we can identify the advanced cirrhosis, but I wouldn't rely on it for the in between. But now we have shear wave and portal pressure, so we have a lot more things that we can do to assess the liver stiffness. But I still like to do a quick palpation.
Hey, Riaz, I just wanted to ask something. There's somebody asked in the panel as well. Comparison of transjugular liver biopsy versus EUS guided liver biopsy in patients who've got ascites. And what is the role of transjugular liver biopsy now that you have EUS guided biopsy?
Yeah, so I think if a patient has massive ascites, that would be a clear indication if a portal pressure gradient was necessary to do it by transjugular, because we don't advise putting a needle, through the stomach, through free acidic fluid, and entering into the liver, because one, risk of contamination, and two, inability to do any meaningful tamponading with the scope against the liver surface. So I would avoid that. Now there are situations where I can, by EUS, I can aspirate and remove the ascites, at least enough so that I have good contact between the stomach and the liver. So I've done that in a few cases. And we have this ascites sucker that can pull out ascites pretty quickly through the 19 gauge needle. So that is a possible maneuver. But yeah, the guiding principle is do not put a needle through free ascites fluid into the liver. Now, aside from that, if you look at platelet count, if you look at INR, if you look at any other parameters in terms of transjugular versus EUS, I would say it's very similar. You know, we go to platelet count to 50,000. Below 50,000, we would probably give a platelet transfusion. And that's the same with IR. They don't like to do it in low platelet count either. In terms of specimen acquisition, I think there's no comparison. Transjugular, you're limited because the transjugular is essentially a 19 gauge, which is similar to our needle. And it is a spring-loaded guillotine type of needle where there's a tray. The tray is 2 centimeters long, and there's a sharp guillotine that shoots over the tray. And that's our old true cut needle that we used to use. And at best, it can acquire 2 centimeters on the needle pass, and you can't do multiple passes. And so typically IR gets a tiny little piece, and they can't go right lobe, left lobe. They can just go wherever the needle takes them in the vein. So when we compare that with EUS liver biopsy, we can get, very, very long core, especially if we follow the guiding principle of a single pass with multiple actuations. Because the key for liver bleeding is how many times you violate the liver capsule. If you only violate it once, and even if you were to take 10 actuations, all of those needle tracks will converge into one common needle track before leaving the liver. And if you have command and control over that final tract with your needle, you can stop the bleeding even before it happens. There are various techniques that I alluded to, but one of the techniques that is a real salvage is if there's continuous movement of blood within the needle tract and your needle is still in that common tract, then you can wait, and a lot of times waiting 3 minutes will stop the movement and things will clot. But if it doesn't, what you can do is you can put your stylet back into the needle and advance the stylet 20-25% back into the needle. What happens there is the most distal 20-25% of the needle is emptied back into the needle tract. And typically there's blood clot in there. There may be some liver as well. And that acts as a human blood clot, blood patch. It's almost like a human gel foam. And that will stop the bleeding because what was in the needle clotted, even though what was in the needle tract kept flowing because of the pressure from the vein. So that almost always will stop the bleeding and patch your hole, and then you can safely remove the needle. So that's a very important safety maneuver.
Wow.
And I'll just add to it, I've actually seen Ken do that live in a case, and it was remarkable. It just completely stopped. It's a very, very sort of simple yet sophisticated technique to control the bleeding.
Mustafa,
Yes.
just to add on, what is the risk of bleeding actually? I mean, what has been seen in Professor Chang's series? How often do we see bleeding from EUS guided liver biopsy? You have to quote it to the patient. That
Yeah, I'll just give you my personal anecdote. Having done hundreds of EUS liver biopsy, I have had 0 bleeds, no significant bleed, no transfusion, no subcapsular hematoma. Now, I think I'm lucky, but it's always possible. But the needle doesn't come out until the needle track is confirmed to have no flow. So essentially, and then after the needle comes back, I watch to see if there's any expansion of the liver capsule in real time. And if there's none, then the procedure is finished and the patient can go home. There's no need to keep the patient in recovery because the mystery is gone. There's no mystery, right? There's no bleeding. Now, can the patient go home that night, go back on their antiplatelet therapy and bleed that night? That's a possibility. A delayed bleed can happen, especially if the patient goes on antiplatelet agents. But short of that, I think this is very safe.
I'm sure you're lucky, but you're very, very good at it too. So let's not take that away. It's always worrying when you're doing this.
I think the key is, having done this and worried about bleeding and seen the key is to watch and wait. I think before pulling out the needle, putting the Doppler flow on and being patient. Oftentimes when we do tumor FNAs, our tendency is get the needle in, get the specimen, pull the needle out. And I think here you have to stop and pause and say, before I pull my needle out, I have to wait for a few seconds or a minute or two. That may be the reason why you're not getting as much bleeding as you might otherwise. That's speculation on my part, I think, Ken.
Yeah.
Just out of curiosity, do you have now a preferred needle type for biopsies of the liver, or like of the various choices, without necessarily giving brand names?
Yeah. So I think I have two go-to needles. The Francine tip, the 3-tip needle, I find gives me the best if I want to do just single pass, single actuation, just one and done out. I'll get the most intact long piece of core. But what I'm finding that I'm doing more of is using the single needle, which is the Mangini needle, which is very sharp. And I'll do 3 actuations in a non-cirrhotic and 5 actuations in a assumed cirrhotic patient. Going back to the other question about fragmentation. Yes, no matter what technique you use, a cirrhotic patient will have more fragmented liver. So I'll do 5 actuations in a presumed cirrhotic patient. And I'll use the technique that I showed you. And the reason why I do that more often is just from a hypothetical point of view. If there's a needle that has 3 sharp prongs, and if it comes across a blood vessel, those 3 sharp prongs will capture the vessel and cut it, and it'll actually slice it here and here. It can slice it in 2 places. And I'm just afraid that, if I run it across a significant vessel and I cut it in 2 places, that bleed may not be stoppable even with my techniques. So, and that's purely hypothetical. But I have heard anecdotal cases of really severe bleeds with that needle. That just makes me err on caution, because 3 actuations of one needle will give me more portal tracks than single actuation with another needle, and it only takes a few more seconds. And now I've got a lot more specimen, and if I need to do the blood patch maneuver, I don't mind sacrificing 20% because I've got plenty in my needle. So that's just my personal strategy.
Good to know. Thank you. And then I think we have Dr. Nadeem Tahami from University of Southampton on the panel as well. And he raised his hand.
Hi, Ken. Thank you very much. I think fantastic talk. You were kind enough to sort of give us demonstrate this technique through a course through Cook recently as well. So I've got a question and I've got a comment to make as well. So comment is, I think you nicely elaborated the importance of portal pressure measurement in patients who do not have evidence of clinically significant portal hypertension. And I think that's where the utility of this technique comes in. So those who have a pressure more than higher than 5 and 6 and lower than 11 and 12. because the key is that these are the patients who are at high risk of decompensating. So these are the ones who will develop hepatic decompensation if you don't observe them and try to sort of address their underlying etiology as soon as possible. So therefore, the role and the importance of portal pressure gradient measurement comes in. And I think clearly going forward, certainly this has a role to offer and help in the management of patients. The question I have is, I know the fragmentation of the tissue is clearly an issue. And if you ask the pathologist, I think the way they tend to assess success is by counting the number of portal tracts provided in the liver biopsy. So, I wonder if you've got a technique because to minimize the risk of fragmentation of the tissue. Now, the reason I'm asking this is because I've got a patient on my list tomorrow morning who has a hepatoma involving the caudate lobe, which is not accessible sort of percutaneously. So if you are biopsying a hepatoma or a malignant lesion, do you have any variation in your standard approach? And the reason, again, I'm asking is you mentioned this role of heparinized needle, using a heparinized needle. So would you use the same in that situation or not?
Yeah, great question. So, so caudate lobe, you can identify that readily as, with identifying the ligamentum venosum, which between that and the middle hepatic vein will give you the caudate lobe. And I would change my technique. I would use probably a 22 gauge Francine tip in this situation, because I want to get good core, but I don't need a large histologically intact benign liver specimen. So I would not use a 19 gauge. I would use a 22 gauge. I would use the Francine tip because it's sharp and it's going to give me the most pristine pathology. And then I would not use high suction. I would not use heparin in my first pass. I would do the standard kind of slow pull, stylet pull back. And I would do probably, 2 or 3 actuations and see what the specimen yields. I would bet that you're just in a single pass, you would get plenty of core. And the reason why core is important is in case your oncologists want to do next gen sequencing, they'll have plenty of tissue. And sometimes, with HCC, to differentiate it clearly, you need some good histology core. So I think for all of those reasons, that would be my needle and technique choice.
Just a quick question. Do you keep the doctor on while doing the biopsy?
I tend not to. I do careful, flow and so on before I biopsy, right? But when I'm ready to biopsy, I want as much clarity, and I don't really need the e-flow on during it. So I tend to turn it off. Maybe if I left it on, I would be more afraid because everything's moving around. But anyway, so I tend to turn it off as I'm actually doing the biopsy.
And does the Doppler flow interfere when you're waiting for just checking the hemostasis in the liver just before pulling out the needle?
No, so that's the perfect time, right? So you do the e-flow before, so you have a clear mapping and pathway, and then you advance the needle forward. And so if you're doing a tumor sampling, right, you would do that. And then if there's any concern about needle tract bleeding, then I would turn on the e-flow as before I pull the needle out, because unlike radiology, they have a coaxial needle a lot of times where they can sample it from the inside needle, and there's still an outside needle which they can inject gel foam. We don't have that coaxial setup. We only have one needle and there's a specimen in it. So if you pull your needle out to go back in to block that needle track, it's almost impossible. And then obviously you don't want to sacrifice your specimen. Yeah.
Great. Thank you very much. It remains for me, Professor Ken, to thank you for a wonderful session, a wonderful presentation, especially when it's so early in the morning in California, in Irvine. I've been to Irvine multiple times. My brother lives there. And when I come, I'll definitely drop in to say hello to you. Um, um, and I'm really thankful to all the colleagues who have joined in. I'm thankful to Mustafa for organizing this talk. I'm thankful to Saad Niaz, Wilson Pharmaceutical for giving the support. Wish you all the best. Wish you a very safe year from COVID. All the best. And dear colleagues, see you next Sunday, same time with a new topic. Take care. Bye-bye.
Bye. Thank you.
Thanks. Bye bye.